Hello to everyone. I'm Jessica Goldstein, Education Program Coordinator at ASRM. Before beginning the webinar, I'd like to go over a few housekeeping items. To make sure we can cover all the content in the allotted time, we will mute everyone's line except the speakers and accept all questions through the chat window at the bottom right hand of your gray toolbar. As an extra precaution, mute your line as well by clicking on the green button next to your name. We will devote about 15 minutes at the end of the presentation to questions. Please feel free to type a question in the chat window at any time. We'll read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. To introduce our speakers today, I will turn things over to Professor Judith Darr, Chair of the ASRM Ethics Committee.
Thank you so much, Jessica, and welcome to everyone. Thank you so much for joining us. This is one of our quarterly webinar series presented by the ASRM Ethics Committee, and we're so proud to be in our third year of this series. Today's topic, transferring embryos detected as abnormal through preimplantation genetic testing, incorporates emerging scientific data with a world of unknowns and mysteries, just an average day in the field of reproductive medicine. But as we learn more about the genetic makeup of embryos through PGT, we struggle to know how best to advise our patients about their choices when so many clinical uncertainties present. We're so honored and thrilled to present three speakers who bring vast experience and wisdom to this arena, hailing from the laboratory, the clinic, and the genetic counseling aspects of ART practice. So it's my pleasure to introduce our speakers in the order in which they'll present. So very briefly, because they all have long and distinguished CVs, let me begin with Dawn Kelp, who's going to present a view from the embryologist. Dawn is the director of the IVF Laboratory at Yale Fertility Center and the associate research scientist at Yale University. She also serves as the off-site laboratory director at the Valley Health Fertility Center in Paramus, New Jersey. And Dawn is a prolific speaker and scholar in our field, and you may have seen her at ASRM annual meetings where she's often a panelist on important topics such as this one. So welcome to Dawn. Next, we'll hear from Eric Widrow, who will talk about clinical considerations for the IVF practice. And Eric is the Chief Medical Officer of SG Fertility that has centers in the metropolitan DC area as well as other U.S. cities as well as cities abroad. And he is the Associate Director of the Combined Federal Fellowship in Reproductive Endocrinology and Fertility, a postgraduate training program operated through NIH, Walter Reed Army Medical Center, and Shady Grove Fertility. Eric is currently a professor and director of the Division of REI, Department of OBGYN at Georgetown University. He's a member of the Resolve Board of Directors and served as chair of the SART Practice Committee. Again, his numerous publications and presentations in the field have been of service to many of us. Welcome to Eric. Finally, we welcome Emily Mounts, and she will give us the perspective from genetic counseling. Emily is a board-certified genetic counselor at Oregon Reproductive Medicine in Portland. She's been a clinical genetic counselor for 20 years and is the incoming chair of the ASRM Genetic Counseling Special Interest Group. In addition to her role counseling patients about PGT, she leads the development of clinical genetics protocols and policies at ORM. Emily is a frequent speaker on this topic and has recently co-authored a paper on counseling issues related to chromosomal mosaicism detected by PGT, something, of course, we'll hear quite a bit about as we follow. So just like Jessica, a few reminders of housekeeping. Each presenter will have about 12 to 15 minutes to present, and we'll have slides that guide them through and us through the presentation. And as Jessica said, we will take questions at the end of the presentation. You can type your question at any time into the chat window at the bottom of your gray toolbar. and we look forward to hearing from you. And just as a plug from the Ethics Committee, we are always open to new ideas about our next webinar, topics you'd like to see discussed. So please feel free to reach out to me or to Jessica or anyone at ASRM, and we'd be delighted to accommodate. With that, I'm going to turn the presentation over to Dawn to begin with the embryology perspective. Thank you, everyone, for joining in.
All right. Thank you so much, Dr. Dar. And thanks so much to Jessica Goldstein for helping organize all of this. I'm really excited about the composition of speakers that we have, because I think all three of these perspectives are absolutely essential for this topic. So I'm really glad that composition exists with this group. So my perspective is an embryologist perspective on transferring genetically anomalous and mosaic embryos. And I have nothing to disclose, and just as the title says, it's an embryologist perspective on this topic. Again, as was mentioned earlier in the housekeeping, if you have questions, please type them in the chat window to the bottom right of the gray navigation pane. I'm going to skip quickly over the learning objectives because we've got lots to talk about and I want to leave lots of time for questions. Basically, we want to be able to discuss and interpret the implications of various abnormal, mosaic, or gray results, and describe the potential sources of PGT misdiagnosis and potential causes of variability with aneuploidy rates between clinics, and we'll talk a little bit about that, and appreciate the complexity of arguments for and against transfer of abnormal and mosaic embryos and the need for proper counseling. And finally, hopefully, we'll leave you with some fodder to be able to establish your own clinic-specific policy or SOP for transfer of embryos with abnormal or mosaic results. So ethical challenges within genetic testing are not new. And when I was very early out of my PhD, Dr. Mark Hughes was giving a lot of discussions about PGD in the 1990s. And those were the earlier days, pretty much before PGS. And so we were talking about diagnosis for a single gene. And I can recall Dr. Hughes talking about, what if you had couples that wanted selection, particularly for something like achondroplasia? So maybe a couple that both have dwarfism and they actually want to select a child with dwarfism rather than having a genetically normal child. What if you had a deaf couple that wanted to select specifically to have a deaf child because they don't perceive deafness as a defect? And so certainly those are exceptional circumstances, but those ethical questions have been around for many years. In the early days, I also recall Dr. Hughes talking a lot about HLA matching and the savior sibling. And there was a lot of sitting around mahogany tables and discussing whether the technology should be used to select a trait like HLA. All of the initial testing was done for genetic disease, trying to avoid things like cystic fibrosis. And so there was a little bit of discomfort, and it's interesting to see just how far we've come in 30 or so years. So I think it's interesting to reflect back on that. We certainly have, in my last 10 years, we've certainly had cases where patients have chosen not to discard embryos that were diagnosed with Turner's or Klinefelter or even Down syndrome, and potentially other single gene disorders. So patients that will just hold those for now and may consider transferring those in the future. And finally, I think the big elephant in the room right now that everybody's struggling with is aneuploidy and mosaic embryos. And that's what I'm going to spend most of my time talking about. But I thought it was interesting to reflect back on some of those other ethical issues. So we all know the graph with maternal age effect and the decline of pregnancy rates with maternal age and the loss rates. And the loss rates for those 42-year-olds are approaching 70% if you consider the loss from a positive beta. So those are pretty compelling numbers. The other thing I wanted to reflect back on, just as a prelude to this discussion, is that I think it's very important when we're comparing data from different papers and different sources, what we're actually talking about. Because if we're testing at the blastomere stage or the blastocyst stage, those are completely different data than one might receive on the abnormality rates from something like amniocentesis or CVS. And those, again, are completely different abnormality rates that you would see from babies actually live born. So just an important point to reflect back on, that you could be talking apples and oranges when you're talking about different abnormality rates. So I think for many of us, the PGT reports that we historically were getting were black and white reports that reported either euploid or aneuploidy. And as if what we were actually biopsying was embryos that looked like this, either euploid or aneuploid. When in reality, the variability of what we could be biopsying with embryos with mosaicism could be much more representative of something like this, where we've got a mixture of normal and abnormal cells within the embryo. So in our hands at Yale, we looked at all embryos biopsied across all ages in our black and white reports. And what we found was we had a 41% euploidy rate across all ages. And when we looked closer at those, we went back and scrutinized those. We, of course, realized that there's a spectrum of gray. And the reality is that it's a spectrum of gray from euploid to aneuploid, and it's not really a black and white result. And when we delved a little closer into our results, what we found was, of those embryos that in that case were classified as euploid, there was a small percentage that were less than 20% mosaicism, which was ultimately considered background. So that's just noisy platforms. There was another portion that we segregated out that were in the 20 to 45% mosaic range. And when we looked at what the pregnancy rates were for those, if we looked at the implantation rates for untested embryos, we were at 42%. The nice clean euploid embryos were 69% implantation rate, and those that were mosaic had a lower but certainly considerable implantation rate of 57%. So what do we mean by gray? Clean, what we're talking about is clean versus messy plots, and I'll show some examples of those. Mosaicism versus noise, and partial segmental monosomies and trisomies. And basically we're talking about easy versus difficult decisions. So in the IVF lab, we make lots of easy decisions. We've got beautiful blastocysts. Of course, we're going to freeze those. Of course, we're going to transfer those. In the genetics lab, there are nice, clean, easy decisions. And, you know, these are the ones that the plots that you always see at ASRM and everybody's presentations. Everything looks perfect, hunky-dory. And the little section on the right is just to show you what those lines actually are. And that is a whole bunch of little tiny data points that are compiling that green line. So it's a lot of different data that's compiled into those plots to determine what's normal and abnormal. This is another relatively easy decision. Obviously, you can see there's two sets of chromosomes all the way along. When you get down to chromosome 18, oh, okay, there's only one copy. So obviously, we've got a monosomy 18. And again, you can see a single chromosome X and a single chromosome Y. So it's a male monosomy 18. Now, the IVF lab has easy decisions on the other end, which is, okay, these embryos look pretty poor. We're not going to freeze those. We're not going to transfer those. Those aren't the choice. Genetics labs also have easy decisions where there's totally chaotic DNA. There's not a lot of noise in the sample. The line's clearly above and below. And so it appears to be a number of mitotic abnormalities. The lab in the IVF lab has tougher decisions. If you've got an embryo like the one on the right that hasn't re-expanded for a number of hours, is that something you're still going to freeze or not? For ones that may have atretic areas in the embryo, is that an embryo you're going to freeze or transfer? Not so sure. And the IVF lab is making these decisions on a daily basis on behalf of the clinical staff and the patient. And so we're making judgment calls certainly all the time. So it's not unreasonable to realize that the genetics labs are also making judgment calls on some of this. And genetics labs can have tougher decisions as well. Not all of the plots are quite as clean and neat and tidy. So, for example, this plot here, do you question and just say, well, it's noisy, poor quality DNA? Or do you look at a couple of spots and say, hey, maybe that's mosaicism? And so some of those judgment calls are certainly being made on the genetics end of things as well. So this paper I wanted to discuss because this one sort of shakes our world up a little bit. Euploidy rates in donor egg cycles differ significantly between fertility centers. And this is Munay's group with a bunch from NYU. They looked at over 1,600 donor egg cycles with 13,500 blastocyst biopsies with a very low no-call rate, a very respectable 2.3% no-call rate. And this composed 42 different clinics with 142 different physicians between 2011 and 2015, using array CGH at the time. The mean euploidy rate was 69%, but the euploidy rate per center ranged from 39.5% to 82.5%. So that's a tremendous variation in the euploidy rate, which says that somehow we're causing between the IVF clinics, we're causing aneuploidy in some capacity. Now, is that something that we're doing with superovulation when we're recruiting eggs that would not normally be ovulated? Does it have to do with the IVF lab and the egg and the embryo handling? Does it have to do with that spindle, which is incredibly temperature sensitive? So all of those are possibilities. Certainly it could have something to do with the stimulation and the particular medications used. Who knows? This slide I just put in as a quick reminder that what's actually happening when we're handling those embryos as embryologists, we've got spindles which are incredibly temperature sensitive going through meiosis, extruding the first polar body, extruding the second polar body. And those spindles are incredibly temperature sensitive. So it would be very easy to imagine that as embryologists, we could be inducing that just simply with our handling in the lab. The other thing we can certainly induce is mitotic errors. Again, we have spindles sorting out chromosomes as cleavage happens from the pronuclear stage to the 2-cell to the 3-cell stage. And if on the second cleavage division, up at this point, we had a temperature deviation and as that cell was going through mitosis, we could certainly be inducing abnormalities within those cells. So I think it's a really important cautionary tale. We do know that mosaicism by embryologists varies, and that could be in part due to the biopsy technique. It could be due to the laser usage. It could be due to tearing or shearing of the cells. Oops, sorry, let me go back there. And biopsy size may also impact. The other thing that may impact is how well those biopsies are washed. So, you know, are they being pipetted up and down and washed well, or I certainly know some embryologists that are afraid to wash that biopsy very well because they're afraid they might lose it in the handling. So there's certainly a lot of variation in how embryologists are handling these samples. This is a statement from the PGDIS group. I don't think I want to go through the whole thing, but I put it in there for reference for everybody to be able to go back to. This, again, is an evolving platform. The suggestion is that we know that there's babies born from mosaic aneuploid euploid embryos. We know that the pregnancy rates are lower and miscarriage rates are higher with those mosaics. And the current suggestion is that with less than 20% abnormal cells, we would consider those normal or euploid, and that would just be considered background. 20 to 80% abnormal cells would be considered mosaics, and then greater than 80% abnormal cells would be considered aneuploid. And they put some suggested guidelines together for prioritizing mosaic embryos for transfer. And that's somewhat still up for debate because what we're finding is that monosomies and trisomies aren't performing all that differently. So This is just a quick reminder that when we look at subchromosomal abnormalities in pre-implantation embryos, about 20% of the embryos, and this is Richard Scott's group that said about 20% of the embryos that would be designated as euploid using conventional 24-chromosome aneuploidy screening will have evidence of a subchromosomal abnormality or mosaicism. Now, if we look at Carlos Simone's paper, the biopsies with 20 to 50% aneuploidy, biopsies with 20 to 50% aneuploidy cells, only less than 10% of analyzed embryos. So the bottom line is that the quantity of gray that we're talking about in the whole scheme of things is relatively low. And the majority of patients will have either something normal for transfer, something else to select from, or they'll be clearly abnormal. So the quantity of gray that we're talking about is relatively low. Finally, I want to talk about risk. To expose to the chance of injury or loss, and I think it's appropriate to think about our PGT patients in this. And so, risk is a chance taken with an unknown outcome, and calculated or informed risk is a chance taken after careful consideration of the possible outcomes. And I think that's where my comfort level as an embryologist is, that I want patients to be in that calculated, informed risk as they're contemplating how they're going to proceed. I don't think that most patients are in the unnecessary risk category, and that would be a chance that's not worth taking after consideration of the possible outcomes. And I think the other speakers will go into that a little bit more. So ethical challenges for PGT patients. If we have a patient that's undergone multiple PGT cycles, exhausted all options before moving on to donor egg or stopping treatment, they've had comprehensive genetic and REI counseling, and I think that's really important. I don't think an REI alone should be the one to counsel for these situations. I think it's really important that a genetic counselor is part of that discussion. But if that patient wants to transfer a mosaic embryo, I'm personally fine with it. I don't really want to see them transfer a mosaic or even an aneuploid embryo while they're still trying to get pregnant, because especially if they're 40 or 42, I don't want them to get pregnant and set themselves up for a miscarriage and then lose their clock for trying to get pregnant again. But if they're at the end of their window and they want to take a chance at a miscarriage, personally, I'm okay with that. I think a patient can make that informed decision. And certainly we've been transferring untested embryos for years, and we know that those with relatively low risk of abnormalities. So the ethical challenges that challenge me as an embryologist are a case like this particular one, where we've got a patient that has 2 normal euploid embryos. She wants 2 embryos transferred, but she doesn't want the 2 males. She wants the aneuploid female, which happens to be an aneuploid trisomy 16, along with a euploid male. And so the big question for everybody is, what do you do? Do you offer an additional IVF cycle and try and get the normal female she desires? Do you allow her to transfer 2 embryos, the aneuploid female and the euploid male? And I think that's a risky situation, because if you let her transfer both of those embryos together, that trisomy 16 is likely to establish a pregnancy and then miscarry. And if you've got a twin pregnancy with an abnormal miscarrying, that's a complication as well. Do you allow her to transfer only the 1 euploid male, or do you allow her to transfer only the 1 aneuploid female if she wants to sort of put closure to that? So these are big questions for people to answer and to struggle with. Another case that we had, the patient has a son, did 5 fresh and 5 frozen cycles for PGTA and desires a female. She has 6 euploid males and 3 aneuploid females, an X chromosome deletion duplication, a monosomy 5 and a monosomy 11. And she wants to transfer females regardless of the ploidy results. And this is what she did. The first transfer, she had a couple of normal females. Then she started delving into the abnormal, the aneuploid females. She ended up with a miscarriage, not surprisingly, from a 46XX duplication deletion, an X chromosome duplication deletion, and a monosomy 5. Then she delved again into an abnormal aneuploid with a normal male, didn't get pregnant. So, you know, these are certainly big questions. And PGT is definitely a balancing act between decreasing miscarriage rates, increasing efficiency, decreasing your time to the baby, and patient dropout and emotional burden. And we're certainly balancing that against the small potential of some embryo wastage and potentially a missed pregnancy. We can certainly recover some of that by delving into those gray embryos, but we're definitely adding risk. So with that, I'd like to pass it on, and thanks so much.
Good evening, everyone. Thank you for attending tonight. And Dawn, thank you for a very informative talk. The title slide is exactly the same. My disclosures are minimal. I'm a board member of Resolve and work with 2 companies, Embryo Options and Counsel, none of which have any input on this particular topic. I'm going to review a little bit of some of the potential sources of error in PGT and talk about some of the arguments from the clinical side for and against transfer of abnormal embryos or embryos that have been diagnosed as abnormal, and talk about some of the limitations of what these diagnostic results mean for us. You can continue to type your questions in the bottom right of the chat window, and Jessica will collect them. I think the quote, "The uncertainties of life find no refuge at its beginnings," is possibly the best quote I've ever read in an ASRM committee piece. And I think it encapsulates beautifully the issues that face us when dealing with patients who have embryos that may or may not be abnormal and have desires to use those, or at least to understand what the implications for using them are. And so the ethics committee paper breaks this down into PGT for aneuploidy, or PGS as most of us call it, PGT for single gene defects, PGT-M in this setting, and PGT for structural rearrangements. So as Dawn helped us to understand, there are multiple potential sources of error in PGT. In the setting of aneuploidy screening, there may simply be false positive and false negative results due to technical issues or due to the inherent weaknesses of any diagnostic test. As Dawn pointed out, mosaicism is suggestive of the presence of more than one cell line in that embryo. And then there are segmental abnormalities. These are large or moderately large sections of DNA that are deleted or duplicated. These can be uniform throughout the 23 chromosomes, throughout the cells tested, or be mosaic, much as aneuploidy can be. Sources of error in single gene testing or structural rearrangements include allele dropout in the case of single gene disorders, technical errors in terms of applying appropriate primers and amplification of DNA, and once again, the inherent occurrence of false positive and false negative results in any given test. The data are very challenging when we try to figure out what the test of a test is for aneuploidy screening. What is the sensitivity and specificity? Part of the problem with assessing these is that once an embryo diagnosed as normal is transferred, if it doesn't implant, or if it implants and miscarries without us being able to test products of conception, we have no way of knowing what the true status of that embryo was. And so estimates of positive predictive value in PGS studies are based on only on the outcome of a live birth. Studies that have looked at products of conception after miscarriage from the transfer of a chromosomally normal embryo have suggested that the accuracy of PGS is 96 to 99%. And based on studies of transferring aneuploid embryo, the majority of abnormal embryos should be true positives. However, as we've seen in recent articles, including the New England Journal piece, it's clearly not universal. As Dawn pointed out, mosaicism is not looking at each cell in the embryo and doing a 24 chromosome spread. It is a bioinformatic prediction of the probability of having greater or lesser DNA. The threshold for saying an embryo is mosaic or aneuploid or has noise in the test is set differently by different labs and varies from platform to platform. And so once again, when you're told that an embryo is mosaic, you're being given a probabilistic answer. Truth is impossible to know in that individual embryo unless we see the outcome from the pregnancy and have testing of that individual or those products of conception. We can't say from a sample that says there's 20% mosaicism or 50% mosaicism that that's a representation of what's going on that embryo as a whole. The embryos, the blastocysts that are biopsied may represent the only two mosaic cells, or they could be reflective of the majority of the cells in that embryo. One of the emerging issues we see in PGT are the diagnosis of deletions and duplications. These are segments of DNA that are either removed, deleted, or copied, duplicated. The reality is that based on the technologies we use for genetic screening, the size of these deletions and duplications tend to be much larger than those that have been typically associated with disease, which begs the question, why do we want to know about them at all, and what do they predict for the future? This notion that we're testing the whole genome, as I'll get to in a few minutes, is really a bit misleading. Whole genome amplification does not mean we amplify every gene, every exome. It means we do a sampling that is wide, but not comprehensive. Seeing mosaicism for segmental abnormalities has the same issues that it does for whole chromosomes. Does it represent, is it a true mosaicism? Is it reflective of the majority of the cells or a minority of the cells? So what are the consequences of transferring abnormal embryos, and what are some of the arguments for it? Well, in the case of single gene testing, it's pretty straightforward. If you transfer an abnormal embryo and the diagnosis is correct, the offspring will be affected. And as Dawn pointed out, and others have, and as the ASRM Ethics Committee points out, there will sometimes be cases of desired abnormality in the offspring, and clinics ought to be thinking about this in advance and have a policy in place. These are controversial cases and create a difficult balance between both patient and provider autonomy. With transferring abnormal embryos that have been screened for aneuploidy, it gets much murkier much more quickly. I remember many years ago when sitting with a fairly senior member of our community who was being asked to participate in an ASRM debate, the doctor said, well, which side do you want me to take? I found that to be a glib and not necessarily appropriate answer. I'm like, well, you should take the side that's correct, of course. And I've come to realize that the ability to argue persuasively both sides of an argument is not due to intellectual prowess or extra experience, but it's due to an absence of directive data. And so I do think that clinics and physicians and patients can make cogent arguments both for and against transferring abnormal embryos if there are no other alternatives. Monosomies are generally considered lethal with the exception of 45XO, which is Turner syndrome. So the argument for transferring monosomic embryos is that one of two things is going to happen. You're going to have an abnormal, you're going to have a failure of implantation or miscarriage, or if it's a false positive, you'll have a normal live birth. Trisomies are more complicated. As we know, several trisomies are compatible with a live birth. Down syndrome is clearly the most well-known, and due to cultural effects, most patients really underestimate the severity of Down syndrome and the disease and disability that's associated with it. 47 XXX is compatible with live birth with a spectrum of but generally minimal abnormalities. And trisomies of chromosome 13 and 18 are almost universally lethal after birth, although rare exceptions have been reported. So the arguments here are transfer monosomies with the exception of Turner, since a false positive test would result in a healthy birth and a true positive won't result in a birth. Don't transfer trisomies at all, or only transfer trisomies other than 13, 18, and 21. Transferring abnormal embryos that are diagnosed as mosaic is once again another step into the gray, as Dawn eloquently described. We have all seen patients who are adult mosaics for Turner syndrome. And those patients have clinical consequences in terms of phenotypic abnormalities, POI, and potential cardiac complications. The rationale for transferring these mosaic embryos varies from person to person and situation to situation. A long-standing argument with very little data to support it is that the embryo somehow manages its abnormal cells. Going back to what many of us learned many of us older folks who learned in residency, that placental mosaicism may be a result of this. There is very little scientific evidence that an embryo can manage or exile its aneuploid cells to the trophectoderm. And other studies have demonstrated that mosaicism exists in both the inner cell mass and the trophectoderm. The argument for transfer is, oh, well, if most of the cells are abnormal, then it'll be fatal and we'll have either a non-implantation or an early miscarriage. And similar arguments have been made for mosaic embryos, that is avoiding Turner syndrome and trisomies 13, 18, and 21. Segmental abnormalities are a step further into the gray. The conundrum here is that the size of the deletions and duplications that are currently reported are large, and most of these have not been associated with clinical disease. And one of the additional aspects of this is that over time, many laboratories have said, hey, we're finding all of these deletions and duplications, but finding those abnormalities in the newborns is rare. And so the question is, if there's so many deletions and duplications, where are the abnormal offspring? Where are the consequences of this? We are starting to see, with additional interrogation of products of conceptions, that some of these may in fact be, some of these may result in early miscarriage. Deletions and duplications and segmental abnormalities are also emerging as a cause of both childhood and in some cases even adult disease. And as our library of known deletions and duplications that are associated with these disease increases, it may make more and more sense to look for these and may give us more understanding. But in the case of these abnormalities, the arguments are once again, if it's a true positive, you're not going to get a baby. If it's mosaic, then we're rolling the dice and willing to base that bet, base that risk assessment, as Dawn put it, on the presumption that a segmental abnormality, whether pervasive or mosaic, is going to be an all or nothing phenomenon. So where do we go from here? Well, first, do no harm, right? And it is very difficult in some of these very emotional contexts to advise patients, where is the harm and how can we prevent it? The complete discussion of that is not something to be lectured to, but to be thought about at the practice and clinician level. And the ethics committee opinion was very eloquent on this. Things to remember are that whole genome sequencing is not what we're doing. We really don't know what we're not testing at this point. Maybe what we're not testing will turn out to be other genetic causes of, quote, euploid loss. Maybe that's what these deletions and duplications have been doing all along. Pre-test counseling and discussion policies are critical. For patients who aren't willing to act on a test result, why perform it? If you're not going to act on that 46XX trisomy 16 that Dawn presented, why do the test? And if we don't know the accuracy of a test, why offer it? While there are certainly some data indicating the value of PGS in increasing live birth rates and decreasing miscarriage risks, this is far from established based on large clinical trials. And what do results with that clinical correlation mean? What are we setting people up, the offspring up later in life by transferring embryos with abnormalities that we have a very poor understanding of? Perhaps it would be better to remain blind to this as we have for many, many years. So I thank you for your attention. I look forward to questions at the end, and we'll hand over the presentation to the next speaker.
Okay, well, thank you so much for having me. I do have a little cold, so apologies if you hear a cough or a sniffle as we go through. I have nothing to disclose. And my learning objectives are, consistent with the other two: understanding genetic counseling issues regarding transferring embryos with abnormal results, and outlining considerations in the development of policies regarding transferring such embryos. And I'm going to touch a little bit more on the single gene scenarios that we encounter with these embryos, and a bit on mosaicism as well. To start, I thought I'd provide a brief snapshot of what it can look like in reality to transfer abnormal embryos, because these clinical scenarios can be so complicated. I won't go into each of these in any detail, but just in the past couple of years here at ORM, we've transferred first a female embryo diagnosed as a carrier of Danon storage disease, which is a multisystem glycogen storage disease in which most female carriers are symptomatic. And this is a patient who had no normal embryos. In fact, all of these scenarios were patients with no normal embryos who initially didn't have a transfer, went away for a couple of years to try to adopt a baby, and then ultimately came back for embryo transfer of 2 carrier female embryos after failed adoption. We transferred an embryo affected with hereditary multiple osteochondromas, or exostoses, which was paternally inherited, along with an unaffected embryo, when the parents who had never intended to transfer an affected embryo simply couldn't separate these 2 embryos, one affected and one unaffected, from one another after they in fact had been created and only the affected embryo implanted. We transferred a female embryo that had been diagnosed as a carrier of X-linked Alport syndrome, a syndrome in which females are at risk for end-stage renal disease. In that pregnancy, the transfer was successful, but the pregnancy was lost at 26 weeks due to maternal renal complications, just kind of highlighting the complexity of the female phenotype in this case. We transferred a male and female embryo that were both affected with non-classic CAH, 21-hydroxylase deficiency, which of course tends to have a mild phenotype, but with this particular genotype, there is a small risk for classic CAH as well, and so the counseling around that was very important. We supported a patient who was planning to transfer an embryo affected with Lynch syndrome, but as she was beginning to start her FET medications, a young family member who had been thought of by the family as sort of the healthiest and most proactive in terms of surveillance was diagnosed with cancer in his 30s, and that prompted her to reconsider the transfer just prior to her cycle. And we're supporting potentially a patient who may transfer an embryo that has a mosaicism for partial trisomy YQ, because in this particular case, we have reason to believe that this result may be artifact. So I think this provides a snapshot of just how unique each case is and how difficult it is to draw lines around what types of transfers we will and will not support. So how did this get so complicated? Well, in the past, as the previous speakers mentioned, we really had these binary results, normal or abnormal, and simply abnormal embryos were not considered for transfer. And here we are in the days of mosaicism, variable expression, reduced penetrance, susceptibility genes, and variants that we're doing PGD for, and it's made everything so complicated. And I think we got here essentially through the increased use of sequencing technologies, which has created this increased volume of pre-implantation genetic testing candidates coming to the clinic, and also increased the complexity of the results. And this is really needing us to, prompting us to step back as a field and take a moment to create some standardized counseling and policies around these scenarios. So as the previous speakers mentioned, and every genetic counselor will say this, the pretest counseling is just so crucial to this process. We really have to assess our patients' goals when they walk in the door. Are they doing testing with the goal of excluding embryos definitively from being transferred, or are they looking at this as more of a ranking and that they would consider transferring affected embryos? We need to discuss upfront the limitations of the testing and give them a sense of what the potential result scenarios are, and at that point assess their intentions regarding their abnormal embryos. Of course, every patient at this stage is hoping that they won't be in this scenario, but I think if we can just get a sense of at the early stage of what their intentions would be, that can be really helpful. And assessing religious and psychosocial beliefs at that point as well. I think as a field, one thing we really need to start thinking about too is using patient-centered language. So when we use the term abnormal embryo or anomalous embryo as the position statement does, it's sending a message to our patients. And when we have someone in front of us who has a gene for example, a skeletal dysplasia, and we're referring to their embryo that has the same mutation as anomalous, I think we can be a bit more sensitive about that and work as a group to use better language with our patients. At the pre-test counseling stage, it's so important to review any policies that the clinic has, and I'll come back to this toward the end regarding transfer and storage, specific to that patient, so not just generic policies, but what are the policies around this particular test and these particular results that may be in front of you. And understanding, as I mentioned with that one case example, that patients certainly may feel differently after they have embryos created and frozen. So there are a lot of factors, as we all know, that go into a patient's potential wish to transfer an embryo that is quote unquote abnormal. Of course, the phenotype is a big one, and how well that phenotype is understood, the age of onset, the severity of that condition, are there preventative or treatment options available for this condition now, and what do we foresee happening in the future? That can be very difficult, as some of these conditions are adult onset, and it may be 20 or 30 years before they would actually present in a child. Personal experience with the condition plays into this significantly, particularly with single gene conditions where a parent may have a personal or family history of the condition and they bring that experience to the table. Moral and religious views, the patient's tolerance of uncertainty, that's certainly a huge factor with mosaic embryo transfers. View of disability and what does that mean for each person, and the motivation to stop the disease in the family. So for some PGD patients, this is a big piece of why they do PGD, is not only to avoid an affected child, but to really stop for once and for all the condition in the family, which of course won't happen if they transfer an affected embryo. And as we all well know, the ability to do another IVF cycle. And then for ourselves, for the providers, what are the factors that influence our perspective? They're really very much the same. We have our own views of these phenotypes. We have our own experiences with these conditions and the biases that we bring to the table, our own personal moral and religious views, and tolerance of uncertainty and disability. But the two things that I think are really unique for providers and that are really a focus of what we're all thinking about are first, our perception of our duty toward our patients, toward the future child, and sometimes even toward society at large. And then something that I hear discussed quite frequently as everyone tries to get a handle on what this means to transfer abnormal embryos is our own perception of and really our tolerance of any potential liabilities that could come into play now and in the future. So I think the provider perspective on these transfers is so important to consider. And at the 2016 ASRM conference, I was a co-presenter at an interactive session entitled Management of Gray Results in PGT. And during the session, my co-presenters and I, some of you may have been there, presented case scenarios to the audience and asked them to indicate whether they would be willing to transfer embryos with certain gray or abnormal results, assuming that a patient had requested this, assuming there were no normal embryos, and assuming that the decision was solely in their hands. And we gave case scenarios for each of these, which I don't have time to do today, but no matter how you slice it, I think these results would have been interesting. But just a few things to point out. I found it fascinating that about the same number of people were comfortable transferring an embryo that was mosaic or inconclusive or had a mild form of CF or had Klinefelters, given how different each of these scenarios is clinically. And I think I was honestly surprised that 25% of providers felt comfortable transferring an embryo with Down syndrome, because in practice, I know of very few clinics that are actually willing to transfer such embryos. So whether this reflects, more of a personal opinion that simply isn't able to be carried out in practice, or whether it reveals a trend toward an increasing tolerance for participation in the transfer of embryos associated with a relatively significant phenotype, remains to be seen, and I think is going to be a really interesting area of research for someone. Now, in the ASRM ethics statement, all abnormal embryos are essentially grouped together, chromosomally abnormal, single gene abnormal, for the simplicity of discussion and to allow the focus of the statement to be on the overarching ethical issues. But there are several aspects of the counseling that are really quite different between transferring, say, an embryo that has positive aneuploidy results and an embryo that's positive for a single gene disorder. So I just wanted to quickly highlight some of these differences by comparing the counseling for a mosaic embryo, for example, versus the counseling for an embryo being transferred for a single gene condition, positive for a single gene condition. So first, for a mosaic embryo, these results may be unanticipated. Hopefully with pretest counseling, they're not totally unanticipated, but I think most patients are still surprised when they're facing the situation of having only mosaic embryos available for transfer. Whereas with single gene testing, these results can largely be anticipated. It's usually not a surprise to patients that they would have affected embryos. And when we transfer a mosaic embryo, really the hope there is that there's a good chance, at least from what we know so far, that the resulting child is in fact chromosomally normal, and that you could essentially call that a false positive. Whereas when we transfer a single gene affected embryo, there's really very little chance that the resulting child, as Dr. Widger mentioned, would in fact be negative for that single gene disorder. And with mosaicism, most often patients have no, of course, personal experience with that condition. Whereas with single gene conditions, very often, if it's a dominant condition or sometimes X-linked, they would have personal experience with that condition that they bring to the table. With mosaicism, it's extremely difficult to outline the clinical course and prognosis for any given particular mosaicism, whereas with single gene conditions, certainly there's variable expression that needs to be counseled on, but the severity of that spectrum can be relatively well defined for that family. And for mosaicism, the counseling concepts are really pretty similar for all patients, the types of things that we would go over with them. Whereas with single gene disorders, the counseling differs quite widely depending on that condition. So you imagine a counseling session pre-transfer for an embryo that's affected with cystic fibrosis versus Down syndrome versus Lynch syndrome. These are very different. And I think in many cases, we need to call on experts to counsel these patients and be sure that they're understanding the range of these phenotypes. And finally, prenatal diagnosis may be helpful to clarify the fetal status in the case of a mosaic transfer, whereas for a single gene condition, we wouldn't anticipate that prenatal diagnosis would add any clarity to that situation. We all know that it's still recommended to verify results, but we wouldn't expect the results necessarily to be different. So I don't think there's any question that having a policy is a great thing for the providers, for the staff, and certainly for the patients to set clear expectations and provide a framework for case discussions. And when my colleagues and I surveyed the ASRM audience in 2016, we found that about 1/3 of attendees had a policy, whereas the remainder were just dealing with requests case by case, or aspired to have a policy, or simply didn't have one. And I love what the ethics statement said, that to the extent possible, the policies should be the product of an informed, deliberative, and collaborative process that includes all relevant personnel in the clinic. And so some of the questions to consider in creating a policy would include, given the tests and technologies you're offering, what abnormal results are possible? Is your clinic willing to transfer these embryos, and under what particular conditions? For example, are you requiring specialist input? Are you requiring genetic counseling? Would you transfer 2 embryos at once, one affected, one unaffected, which can complicate prenatal diagnosis? Would you transfer them into a gestational carrier, and so forth? Are you willing to store these embryos, even if you're not willing to transfer them? What would prompt you to change your policy? So are you looking for eventually having data or standard of care change? And if you do change your policy, how do you plan to notify patients of these changes? So the pre-transfer counseling for patients who do proceed with transferring an affected embryo is just as important, of course, as the pre-test counseling. And as we all know, these patients are often facing a choice between transferring an affected embryo and having no baby at all. So these are very difficult choices. And I think we have to acknowledge the possibility that these results, certainly with mosaicism, they can be false positive, but with single gene, patients need to assume that these are accurate results. We wouldn't want a patient transferring an embryo hoping that it was an incorrect diagnosis. Again, ensuring understanding of the disease course and variability, considering the perspectives of both parents, which is so important, especially in cases of single gene disorders where one parent is affected and one isn't. They may have very different perspectives on the burden of that disease on their family. And sometimes I'm surprised which parent it is that actually is more willing to go forward with the transfer. As I mentioned, single versus double embryo transfer, documenting informed consent, of course. And then I just wanted to finish up by saying a few words about the interface between, the embryo transfer and sort of what happens from there with the other specialists. So we need to be discussing with patients who transfer single gene positive embryos, when is it going to be best to disclose this child's status with them, with providers, with the family? And that's going to be very different from condition to condition, depending on what the condition is and what the need would be for surveillance as that child gets older. We need patients to understand, what is the prenatal and pediatric perspective on this condition. So for example, with mosaicism, when this is diagnosed in a pregnancy or certainly in a child, it's cause for concern, so, or at least for a more extensive workup. So the decision to transfer these embryos may be met with surprise or even disapproval from specialists in perinatology or pediatric genetics who may not be familiar with embryonic mosaicism as we understand it, because mosaic aneuploidies of almost every chromosome have been documented in live birth. So the better we can prepare patients that they may encounter that perspective when they leave our office, I think the better, prepared they will be for those conversations when they inevitably happen. And so this evolution of care where these patients may have future involvement with other genetics or subspecialty providers is really important to sort of get everyone on the same page. And so in conclusion, I want to say this is really obvious, but embryos will become pregnancies, babies, children, and adults. And in many cases, they're going to carry these embryonic genetic diagnoses with them. And so I think it's important for us to understand the perspectives of these other fields who will care for our patients as they go through their pregnancies and births. And, all major genetic societies have ethics statements regarding the genetic testing of pregnancies and children. So I think it's important for us to think about how these statements relate then back to the testing of embryos that are transferred with a known genetic status. And this relates primarily to adult onset conditions, but predictive, there's nuances to all the different statements, but essentially they all say that predictive genetic testing for adult onset conditions generally should be deferred unless there's an intervention that can be initiated in childhood. And that really the best interest of the child should be in mind when the decision about offering genetic testing is made, and that child and their family should have genetic counseling along with the testing. And we have to remember that there's a small subset of conditions, Huntington's would be one, where only a minority of at-risk adults opt for genetic testing. And so typically these people who are at risk would have what we call the right to an open future. So they would be able to make the decision about when they want to know their status. But if they've been tested as an embryo and presumably then know that status from a young age, or at least an age that the parents chose to share it with them, we've sort of deprived them of that right to not know. And doesn't mean we shouldn't transfer the embryo. It just means that it's definitely a point that should be made in discussion with the family. So on that note, I will conclude and try to get my voice back before hopefully some questions.
Thank you very much. I'm going to direct the first question to Dr. Widra. Would you ever consider transferring an embryo diagnosed as trisomy 18 if a patient told you that she is aware that there might be a 1% chance that the embryo could be normal, and she was fine with doing prenatal testing and terminating if abnormal?
Oh, it's great that I was muted, because then I had like a practice run at the question, and now I can try again. It's an excellent question, and as I started to talk while I was muted, I started to stutter, and I realized that I'm not sure how I would react in that situation. I think if there are no other available embryos with proper counseling, that there's an argument there. I could tell you, as a matter of policy in our practice, we would not do that. The problem with those hypotheticals that patients present is that what they think they know may not be reality, that what a patient might choose to do after the first trimester with an abnormal prenatal test, or what it might be like for them to watch a child die in the nursery or after a tortured life of only a few months at home or in the hospital, is a very difficult thing to process. And so I think it's an unusual person who can really grasp the implications of those types of decisions.
Thank you. This next question is, I have a question regarding segmental mosaicism. Assuming that most cells carrying large deletions duplications won't be viable and will likely be lost as either abortions or as lost cells in healthy newborns, whereas smaller deletions or duplications may be viable and carried forward, but with a higher chances of being associated with disease in the offspring, such as intellectual disability or genetic syndromes, shouldn't we favor transferring embryos with the former rather than the latter?
I'll take a quick stab at that. We can't diagnose the latter right now unless we know what deletion or duplication we're looking for. Those disease-associated ones are so small that routine screening with PGS doesn't detect them. Dawn, am I on target with that?
Yeah, sorry, I was muted too. I think I'm there now. Yeah, I think you're on target.
Wonderful.
Yeah, and I think, just to add to that, I think, the thought is correct that we're hoping that most of these are sort of all or nothing, but the fear is that we don't necessarily know where that limit is, right? So if you can have a live-born baby with a full aneuploidy, then you certainly could have a live-born baby with a segmental aneuploidy. And so it's really difficult to know how to apply the literature to these cases because there's so little literature on any one particular segmental aneuploidy that, it's just really difficult to know how to apply that and if it can give you any sort of reassurance or guidance, on that particular embryo. So, yeah, I totally agree with the idea, but it's difficult.
Here's another question for Ms. Mounts. The optimal follow-up of transfer of a mosaic, and what is the optimal follow-up of transfer of a mosaic embryo, and how confident can we be in those results in CVS versus amnio versus array versus karyotype?
Yeah, well, that's a good question. It's a tricky one. So, the gold standard of prenatal diagnosis remains amniocentesis because it is simply the only test that's looking at fetal cells. Now, having said that, it's obviously done later in the pregnancy, and even an amnio is not perfect. So while we can give patients a lot of reassurance if they have a normal amnio after mosaic transfer, we still have sample limitations and all of that. I do think, though, that there are patients who undergo mosaic transfer who can benefit from a CVS. It is sampling essentially the same tissue that we're sampling on trophectoderm biopsy, but it is more fully developed at that point, and so I think there are patients who, understanding the limitations of CVS and the potential need to do amnio anyway, would still opt for CVS. When we get into things like non-invasive, prenatal testing and serum screening and other screening tests, I think, it gets even trickier, particularly when we consider that most mosaic transfers probably that have happened, at least so far, have not been of the common aneuploidies that those tests are designed to detect, 13, 18, 21, X, and Y. So if we transfer an embryo with mosaic, monosomy 5, none of the current clinical screening tests would be really validated for picking that up. And so we would be talking about really only diagnostic testing. And even then, there's a question about whether, should we be counting additional cells? Should we be doing, as you mentioned, a microarray to look if it was a segmental abnormality? So these are really, I think, case-by-case conversations. And again, where that interface between, the reproductive endocrinology clinic and the perinatology or OB clinic needs to be really, really tight, I think, in these cases, so that the patient is not left to try to explain all of this, which we know has happened in many cases, and it becomes very chaotic. So to provide that continuing support to the patient as they leave our office.
We have time for one last question, and this is to all the panelists. With apologies that this might be a little off topic, where do you think CRISPR Cas9 will come into play with these abnormal embryos? Do you think that we will be able to edit these embryos in the future, scientifically and ethically?
It's Dawn. I'll have a go at that one. I do believe it's only a matter of time, and I believe it's going to come a lot quicker than we're all anticipating. I think it's going to be certainly probably within the realm of our grandchildren kind of thing. So I do think it's coming. I think it's pretty inevitable. It's just a matter of time.
I agree with that. It's not necessarily applicable to all of the things we've talked about today, but certainly for single gene disorders. And it will be an interesting ethical debate as it comes online. I'm hoping to be retired by then.
But, why wouldn't we fix something if we could? I mean, if we could just fix those abnormal, the tough part's going to be getting the research and the implications to know that we're doing it safely and, that we're not inducing other errors. And that's the really scary part, is the research to transition through to the competence of actually being able to do it really efficiently.
I think that's beautifully put, actually. Assuming very good or near perfect technology, fixing a broken gene seems like a great idea. We would do it. We have ongoing trials now in children and adults with gene therapy. But getting there is going to be exceedingly difficult, and there's going to be a lot of bad outcomes. I am not particularly moved personally by the slippery slope argument. I find that to be a little too facile to argue against it. But as we've seen and I think Dawn really described it very nicely in the beginning slide, talking about HLA matching for Save Your Siblings was very challenging at first. And now as a plurality of clinics offer sex selection. So it's not hard to imagine clinics offering gene editing along a gradient that may be troubling to some.
Yep. Well said.
Thank you very much to our presenters and to our attendees. The session was recorded and will be available on our website in the near future. Please keep an eye out for the announcement of our next webinar topic. For any further questions or comments, please don't hesitate to contact me at asrm@asrm.org. Attention, Jessica. This concludes the webinar.